I think the last but not least, I would like to invite Dr. Huang Wan. We talk about the DCB in CTO PCI, what we have learned from cases.
Now I just say good afternoon, everybody. Thank you for still stay here to encourage us to talk. My topic today is DCB in CTO PCI, and I can sharing some cases from my centers. As we know, the CTO PCI is the challenges for interference because cholesterol often have non-lesion and diffusity, so we requires a longer stand, or sometimes we put full metal kit. So in the outcomes, it's high risk of MACE or reduced PCI. Looks like right futures. The full metal kit standing in the corridor, so it's going to look like a tube, maybe no motion. With the chance today is leaves Latin behind after intervention. DCP in use in some situations like derevolutions, diffusion, bifurcation lesion, or patient with diabetes and high blood pressure. Some also ACH. Some data show that DCP may be useful and effective in some selected lesions. And what about DCP in CTO PCI? A big European disease of CTO PCI, and about the analysis about more than 40 CTO PCI, and then categorized according to the CTO DCP use. And the results in DCP groups in the length stand and the volume contrast, the peripheral temperate and peripheral perforation, and also the procedure time is much lower than compared with DS10. And with bifurcation lesions and DCB DCB group, maybe the double stand technique much lower, significant lower than DS group. So this might be useful in CTO lesions. Now I can share some case from my centers. Patient male 60 years old, having smoker, admitted due to angina and no ATT trend, normal labs, zeros, and no TNT elevation, and lab function is normal. So it's the CAG patient in the right, we can see the non-CTO lesion little CTO, little right RCA. And so, and after we use a higher second and figure out after the successful the lesions, the quite wide cross lesions, we use cutting balloon 30 and set to prepare the lesions from all of the lesions. And after lesion preparation with cutting balloon, we use the lesion now is opened. The dissection is limited, maybe Thai A dilution, so it's suitable for DCB. So I will try. We put. Sorry. Sorry. So we took 2 DCB 3.5 30 overlap in the lesion. Then the final results doesn't look very good. And the patient after 3 months, patient has chest pain, so we put the patient, we check the angio again, but the results now still good after 3 months, and we see the early positive remodeling in the lesion. And before and after 3 months. It look very good. And the second case is female 68 years old. He had diabetes and hypertension, and admitted due to angina and no activity trains, normal leptin rounds, and no anti elevation. Nerve function may be mild reduced, and mild hypokinetic of the apex and the anterior wall. So the ECG, you can see patient CTO is a mixed LED and very diffusion. That after the successful the wise recorded lesions, we prepare lesions with the NSE balloon 2.5 15 and from liter to the proximal. And after that, we use 3 DCB from put from the liter to proximal. So the all of the lesion to cover by DCB. That's the final results look very nice. Yes. A little digestion proximal. You can see in the lesion side maybe type E, so suitable for DCB. And patient for 6 months later, we see very nice the LED. So the lesion now is still zero, and the positive demuralinia now we see the LEDs are bigger than normal. Here, that's the last case. A patient now 65 years old. So we can see the sub-occlusion in the proximal artery and distal artery. That after the wise successful record lesion, we prevent lesion by scoring balloon 2.5 15. So after that we use 2 DCB. It's a liter DCB 2.25 and 25, and the proximal artery we use a DCB at the side 30 35. And now is final results. Not so good. So after on 1.5 years, patient has chest pain, we check again. We could see the another results as RCA, and now look very good. Yes, that's after PCI and after 1.5 years. So some summaries. CTO PCI is now still changes because the complete lesions, high risk of complication and during PCI and not good outcome compared with non-CTO PCIs. Maybe DCB is now emerging as a promising strategy in selected CTO lesions, but we need to the last study to confirm its effectiveness. Thank you so much.
Thank you, Dr. Wan, for very interesting cases. So now we have some time for discussion. May I ask our colleagues and our panelists here to have some comment or some question for our speakers before?